That is awesome. My cardiologist is here for a conference. I love it. Come with me to Chicago.
Well, he's running the heart failure with the palliative care and hospice.
Say heart failure and
Palliative care and hospice.
oh, so for your end-stage heart failure patients.
Yeah,
Awesome.
so there's a relatively new hospice program here particularly toward heart disease patients.
That's awesome.
So we're trying to take patients that are on butamine drips.
Great. Like I said, it's we need to, hospice needs to be open to taking those medications, but it's a cost.
It's a cost because Medicare
Right.
only pays a certain amount of
$100
money.
a day. I know.
That pays for like 20 minutes of vitamins.
Yeah.
So, for each of these cases, and I'll just read through them and then we can spend a few minutes talking about them. The discussion questions are the same, and basically, I chose these cases specifically because there really is not. I don't want to get tracked into one answer or one approach. I really want to have a discussion among us as far as how we handle things, especially with the understanding that you're not going to have the outcome of these cases necessarily be exactly what you would have wanted in the beginning. But without further ado, I can read the case and then we can kind of just dive into a discussion, go over the questions. So the first case is your service has admitted an 86-year-old woman from a nursing home for sepsis with an unclear source. Her past medical history includes COPD, systolic CHF with an EF of 35, dementia, and CKD stage 3 at baseline. As a result of a critical illness that occurred 6 months ago and culminated in a cardiopulmonary arrest, she's chronically ventilated through a trach. She has a PEG tube and a chronic Foley. Since that time, she's been hospitalized 4 more times, with her inpatient stays averaging 25 days, each time for sepsis related to infection acquired via an indwelling device. Since the second readmission, she has had stage 4 sacral pressure ulcers. She's not returned to living in the community since the index hospitalization. Her current illness has been marked by the growth of pan-resistant VSBL-producing gram-negatives from multiple sites, including her blood, has intermittent use plugging with DSATs requiring an emergent bronch twice, progressive worsening of her creatinine to the 3.5 to 4 range, and progressive anasarca. When she has pain or agitation, opioids and benzos consistently cause hypotension. Once she had to go to the ICU for that, and therefore they are no longer part of her care. Since her arrest, she's been in a minimally conscious state, incapable of meaningful communication. Decisions about her medical care are handled by her son. The son persistently refuses to engage in discussion of alternatives to her current full-code do-everything approach to care, and states, "I told the last hospital doctor I don't want to talk about any of that. I know she is very sick, and I just want you to do what you need to get her better." He returns calls from the care team infrequently, but will answer to consent for emergency procedures when a crisis occurs, and visits briefly about once a week, which is the sole opportunity the care team has to communicate with him. During these visits, he typically states, "It looks like she's getting better," or "She told me she's going to pull through this," in spite of her unequivocal clinical worsening, which the care team has directly communicated. And the fact that no one else has witnessed meaningful communication from her. The son is congenial and receptive when the hospitalists report workaday minutia, like changing her independent to colistin because of new cultures, but he reacts negatively whenever caregivers attempt to broach goals of care conversations, and consequently the hospitalists have become increasingly resigned to the current approach. Both nurses and the hospitalists note progressive worsening and signs of suffering demonstrated by the patient, like grimacing, writhing, and tears, and the nursing staff is in distress over the emotional toll of not being authorized to provide palliative measures. The administrators are citing that the patient's been in-house in a monitored vent bed for 52 days and are asking that you do everything possible to address the situation. An ethics consult was called and the committee discussed the case but was unable to recommend any action.
Really?
So the first question is, how would you approach the doctor-patient communication in this case? Meaning, who would you go to, how, when?
Do you want me to start?
You can start.
I've never seen a case like this before. Actually, maybe Monday. So actually, those who were at the talk, this kind of fits my example of the lady with the blue toes and the blue hands and multiple pressors and images compromise and everything. And almost saying the same thing. I don't want to talk about it. You have to get her better. You made her this way. If the doctor listened to me, then this would have never happened. On top of that, she's swinging a few because you can just tell she has her own issues. She's never around in the morning. She always comes in like disheveled looking, and so there's all there's other factors here. And so, how would you approach a doctor-patient communication? So I guess I could, instead of giving you the answer, I will ask, if that's okay, so how would you approach this case? How would you approach the son? How would you grab that attention for the 2 minutes? I do role playing too.
I mean, I think in this situation, the real issues or your options are that, you come out with a sense of, immense urgency. Say, listen, you haven't been coming in very much. I really, really need you to come in. Let's set up a meeting. Or you get what you can from him. You strike when he's here. You take the 5 minutes of his time on his own terms. But a lot of this is on whose terms does the communication take place, and how sort of forward are you with the evidence about this woman's condition, and how do you present that evidence?
So yeah, the first thing is making sure that, so I'm going to take this approach with how to set up a goals of care discussion, Spike's approach that you're aware of. So how, first of all, what are other doctors saying, and are other healthcare providers? I'm sure this patient has probably every consultant for every organ on the case, right? So are people saying, hey, things are getting better, there's no fever, so the patient hears better, and things aren't getting better. I was in a case with neurosurgery where the surgery went well, so the neurosurgeon said everything was going well, and we put in a PEG tube so she could eat and get stronger. Right? So first we have to make sure that the messaging, right, is the same. Once the messaging is the same, then, or even in these cases, limiting the messaging from people and saying, look, getting all your providers on the same page, saying, let me do the talking, not let the hospitals, for example. And saying, you know what, this is a very complicated case. I will be the siphon on communicating the issues, because there's really nothing complex here. This is medical futility. So when they react negatively, whenever you attempt goals of care conversations, how do we make that negative? So he said, I circled the word better. I just want her to get better. I said, I do too. You have 5 minutes where we can talk about how we can get her better, right? It's like an analogous to, well, you have to do everything. You have to save her life. I can't kill her, and so you have to, like the DNR issue. Okay, I understand we want her to get better. I want her to get better too. I want your mom to get better. Can we talk a little bit about what it means to go through a resuscitation? Excuse me, do you know what that means? No, I saw it on TV. They just, it's like the show ER, they just get better. I said, well, not necessarily. So is it okay if we talk about it? So getting permission, right? You have to get permission to talk and focusing on better. And then getting that permission, that 5 minutes, and then that 5 minutes can turn into a whole hour. It's rare, if you approach it, I think, with the way, we need to talk about goals of care. That's not going to work in a case like this. Sometimes it can, but not in a case like this. So when he reacts negatively, whenever caregivers attempt to broach goals of care conversations, that negativity must be from a specific reason. Maybe the approach was wrong. I'm not blaming the healthcare team. maybe it wasn't done at the right time. Say, I'm with you. So the key is, we're together here, right? I also want your mom to get better. Can we just talk about the medical facts? Do you know why we changed from imipenem to colistin? Oh, that's good, right? I said, well, is it okay if we talk about that? When the patient's on colistin, that means they're almost dead. We know that. So, that's how I would approach the doctor-patient communication, clinging onto those words that they use, and then using motivational interviewing techniques to, and which is, what do you call, we're using reflections, you know. So I see that you're very concerned about, you know, your mom and you want her to get better. Let's talk about that.
Where do you fit in some
So-
sort of the family religious and how you view these conversations? Or spirituality?
I will also answer that. Also, I'll get to that. The other thing is sometimes it helps where if there already has been such a strained relationship between providers, getting a palliative care consultant who may not have that strained relationship totally helps. Not that the hospitalists can't do it, but there's always so much anger directed at that person because that person, that family looks at that hospitalist as a cardiologist or whoever it is, as that's person responsible. So a fresh face in these situations, whether it's ethics team or palliative care team, can be tremendously helpful. And or sometimes it's a new hospitalist who's on service, can start fresh and say, hey, look, you know, I know your mom's been in the hospital a very long time. I reviewed the case thoroughly. I had a very good sign-off from my colleague, and I want to work with you. And we're gonna help your mom. We're not gonna give up care, because care continues. So you got to build that psychological relationship back on board. As far as spiritual, religious things, you know, that if that comes up, you can't fight it. I'm not gonna convince give me an example. So, yeah, I had an Orthodox Jewish patient now, who they were adamant that they can't withdraw care. It's in their doctrine. I'm not going to change that. So I'm going to work with what I have.
Well, I guess that was really the source of my question is,
Right.
do we even know if that's a factor?
We don't know, but that's the exploration, right? That's when you use the nurse technique, the naming the problem, understanding the emotional problem, respecting it, supporting it, and exploring it. Because maybe it is religion. There's something driving this guy,
Exactly.
and you have to take your time and capture him at the moment and explore the deep emotions underneath. Right? And it's impossible for me to do that when I'm on hospital service. Because I don't have the energy or the time, because my body language will give it away. I'll be fidgeting with my pager, I'll be looking, I can't. So, yes.
The other thing, with regards to the approach and trying to engender confidence, trying to feel like you're on the same page, if I were walking into this situation and saying, you know, I would like her to get better as well, part of me would feel as I'm lying to him, or if it's the issue of my definition of better is different from his definition of better.
So-
How can I reconcile that in my mind as I'm approaching?
So like we talked about costs, right? You can't go into a case thinking dollar signs for palliative care. You want the patient to get better. You know they're not gonna get better. You know that better means palliative end of life,
Right.
right? But the key is to take advantage of that statement, right? And capitalize on that moment and help him understand that we're on the same page, and eventually, I would say 98% of the time, it takes some time, but they'll come around and understand what better means now. It's not
It's changing their perception.
changing perceptions of what better means. So,
Better can mean different things in a case where you don't have terminal illness too.
Right.
I mean, I think that we incorporate that a little bit more easily into the case where somebody comes in